Oh, hey, Chris.
Hey Chuck, how are you?
I'm pretty darn good. What about you?
It's pretty darn hot where I am. It's a scorching day here in St. Louis, and unfortunately the air conditioning for the building where I do clinic is not working. So they've got all sorts of fancy, portable air conditioning units pumping cold air everywhere. And if you're in the right spot, it's great. But the exam rooms were very, very stuffy.
Hey, think on the bright side. Patients want to get in and out, I'm sure.
Yeah, I think they realize how quickly I move now. So, and then of course was doing some academic work this afternoon, and then got asked to help reduce a lady's distal radius fracture, which just had happened a couple of hours ago. So I don't think I've ever seen anybody that quickly and blocked them and got them reduced, even when I was in the ED as a resident. So moved pretty fast.
Nice. Yeah, St. Louis is a bit sticky now. I did bike into work today, and even at, in the 5 o'clock hour, it was 80 degrees and humid. So, but, I grew up in Alabama. These things aren't so terrible to me. My northern wife is a different story.
It just seems to be getting, even in my short tenure in St. Louis of 12 years now, it seems to be getting warmer, and who knows why, but
Who, who knows? So we have a good
so we
episode.
yeah.
We're going to do a case and then hit six journal articles from Nash and Magdalena.
Yeah, so Nash and Magdalena sent us 6 articles. This is part of our quarterly spotlight for JHS articles. So we appreciate the partnership with the Hand Society, the JHS editorial board, Greg Merrill, Nash, and Magdalena for letting us talk about these articles and hopefully entice people to browse online or pick up the latest print journal for JHS.
Absolutely. And then we have a really special Hand Society event coming up.
Yes, we are doing a live taping of The Upper Hand on Friday afternoon at the Hand Society in Boston. So it'll be on September 18th at 4 p.m. Location is still to be determined. But make sure you come and get a seat because I think it's going to sell out this year. I don't know, we're selling
Oh,
tickets.
for sure it would if we were only selling tickets. And if you don't get enough in Boston, you can fly over to Edinburgh, and Chris and I are doing a live podcast for the British Society of Surgery.
You are so in demand, Chuck. I mean, all the promotional materials for the meeting, for the British meeting, are talking about how Chuck Goldfarb was going to be there, and little old me still got room to go to get onto the main billing, but I'm happy to support you in all your endeavors.
Well, you are kind. You are kind. We're going to new heights together.
So, oh, is that a plug for the Kelsey podcast?
My
Yeah,
wife is an avid listener.
there you go. Ka-ching, ka-ching. So, speaking
Yes,
of, why don't we acknowledge our friends over at Practice Link before we get into this case?
absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand. And PracticeLink was kind enough to allow our fellows and their spouses and Dr. Brogan and I to join them for a Cardinals game,
I
which
heard.
it was quite warm, but we were inside, which was really nice. So
Yeah, I was talking about the beauties of baseball. For me, there really is almost nothing better than a 70-degree day in the afternoon watching a baseball game. But the flip side is also true. In the wrong weather, baseball's not so fun for me.
the beauty for me of baseball is nachos and barbecue. So I checked both of those things off the box. We actually stayed for the majority of the game. I mean, we stayed until I guess the top of the eighth, and then I was like, I gotta go. And I also wanted to give the fellows an opportunity to leave if they wanted to leave. I feel like if as the attending, it's like at like an industry dinner or a journal club, if you're still there, they're still gonna be there. So I try to like leave a little bit early so that they can leave too.
It's true. It's true. I was at Cardinal Stadium recently, but not for baseball. My birthday present from my wife, which was somewhat for me and somewhat for her, was Noah Khan tickets. So that was at Busch Stadium, and it was a really great show. We had a lot of fun.
That was a coveted ticket from what I understand. So I'm sure the show was amazing.
It really was. It was great. I don't want to say I felt ancient, but I didn't feel young.
Before we get into this case, I'm just gonna quickly mention the rip of concerts that we've been on, which is
Oh,
ridiculous, but
do
it's been
tell.
all. So one week was Benson Boone with the family, followed by a few nights later, Lil Wayne. Uh,
with the family?
no, dad of the year over here. The following week, Tiff and I took a little adult trip, and while the kids were at camp, and we saw the Foo Fighters and Olivia Dean in Toronto back-to-back nights.
Wow.
Which is pretty incredible. And then this Sunday, we got invited to see none other than Guns N' Roses at Busch Stadium. So that'll be it for a while. But it's been fun. I'm really into the live music and concert thing recently, so it's been a blast.
Wow, that is something. I think I mentioned to you the last time I saw a concert in Toronto was with Dr. Calfee. We
Ah,
were we were walking to some event and we're like, why are all these people here? And Drake was alive and Calfee was motivated, and we were two old guys at Drake and had a good time.
yeah. So I last aside before we get into our case, we
Last,
were
we promise.
we were traveling and we met a couple from Canada and they said they were from Toronto. And I was like, oh, my wife and I were going to Toronto to see blah blah blah. And she's like, hold on. You don't say the second T. It's Toronto. Otherwise, they will know you're a tourist. And I'm like, I'm pretty sure they're gonna know I'm a tourist for so many reasons. But
I
but
learned
yes,
something new.
just so you know. But Calf was also at Lil Wayne too, so he's got good taste. All right.
Yes,
So
yes.
I mentioned this case actually a few months ago on the pod about a scaphoid waist non-union and somebody who was away for a while in a environment where they lacked outside vitamin D exposure. But now he finally comes around for the surgery, and I'm chatting with our new fellow, Sritha, who's fantastic. She did her residency in New York, just like I did. So we common bond, and we're chatting about cases and we're talking about the way to approach this. And I asked her, what do you want to do? And, she starts asking about a volar approach. And I say, I try to do everything I can not to go volar. So say this case, scaphoid waist non-union, no attempted treatment in the past. So it's not like he's had prior surgery, wasn't even casted for it. On the x-rays, he's got, a visible gap, some cystic, a little bit of cystic change, but nothing crazy going on the proximal pole. I ask for a CT. He doesn't get the CT. I look at the x-ray again. I say, I'm probably fine. On the lateral, there is essentially no flexion deformity. So how are you thinking about how to tackle this case? And, I did check his vitamin D level when he was 32, and the bottom of the normal limit here is 30. So he's on some supplementation and trying to think about how to tackle this case. Would you still go dorsal or would you try to go volar to get maybe a little correction?
Love this case. I will comment on the vitamin D. I have been more aggressive about ordering vitamin D, and I had a similar twice treated scaphoid non-union. Got the vitamin D. It was 11. And
Oh,
so then I was trying to figure out how long do I have to wait? Well, labs normalize in 6 to 8 weeks, apparently, but the real improvement can take 3 to 6 months. And your situation is a little bit different. So I thought that was interesting. That was open evidence guiding me. Because where do you look for information like that?
yeah,
Certainly,
exactly.
yeah, I don't read endocrine journals.
Yeah,
So,
there are some surgeons that orthopedic surgeons that will, continually work to get their patients not only within normal, but like to 80. Just I mean, you got to heal the bone. So
yeah, absolutely. So great case. I'll tell you what I'm going to do, and I'm pretty sure you didn't do the same thing. But in this situation, what I've done the last few years is definitely go dorsal, um, and do it through a small incision. Um, and I will put a scope in the midcarpal joint to look at the alignment of the scaphoid, potentially bone graft through that site to keep my incision around the scaphoid minimal and to assure also through the midcarpal scope assure that my reduction is satisfactory. It's just a different approach, but I think you can get away for sure with just going dorsal with a longer incision if you want, a little incision you want. The benefit of a little longer incision, as long as you protect the blood supply at the dorsal ridge, is that you can see it, you can bone graft it, and like you, I would prefer not to go volar. What'd you do?
so I did everything except small incision and scope. So with dorsal. Went with a bigger
Perfect.
incision. I guess my question is, what advantage do you think that the mid-carpal arthroscopy gives you? Is it accessing the non-union site in a minimally invasive way, and then the incision you're making is just enough to get the screw in?
Yes. So it by putting your scope in the midcarpal joint, you are directly looking at the waist of the scaphoid in this situation. So you can really assess alignment And if you choose to do that, then yeah, then you absolutely can get away with just a very small dorsal incision, bone graft through your incision and through your drill hole, or bone graft a little bit through the midcarpal joint if you want, as long as you have you're not using fluid, of course, in your scope. So it doesn't, it's not a big deal. It doesn't take long, doesn't add much to the case, but does give you visualization, which is nice that you're not, doing too much. It's hard to make the case for that, for doing the arthroscopy. I think the way you did it is simpler, faster, and equally efficacious, I'm certain.
So I think one thing that his alignment was already not, pretty good. So there wasn't a whole lot of work to do for that. One thing I remember from training and hearing, I think from Calfee was, it's always hard to really know exactly, like when you're grossly inspecting, it's hard to know exactly where that non-union is, because that fibrous tissue can sometimes look like actual cartilage on that outside of the scaphoid. Do you have any pearls for how to localize it? Are you using, especially if you have a smaller incision, are you going to take some of this down? Because we know that there's some cysts within the scaphoid itself. Do you have to clear those out, or can you just be relatively minimally invasive and just pack through the drill site?
Yeah, it depends a little bit on the degree of displacement, the degree of cyst formation. I think in most cases you can go through the drill site and be just fine. But if I am scoping and I have trouble seeing it, then I might open it up just a little bit at the site. I have no problem opening the non-union site, but most of the time, at least for me, and I assume for you, we're talking more about a non-displaced proximal one third or proximal pole fracture non-union. And those I don't open it. I just bone graft through the drill hole. This is a little bit different. So I think if depends on my degree of satisfaction with kind of the what I see and my ability to pack it successfully.
Yeah, I just couldn't stand the cystic changes being there. So, I was very careful to skirt around the dorsal ridge and
Mhm.
not tamper with the dorsal ridge, but really go around the radial side. Put a K wire in, localize the non-union site just to confirm, and then wedged it open with an osteotome, and then scraped out, that cyst. The cyst bothered me. I just wanted to optimize my chances of success.
I think you did. I think what you did the absolutely appropriate way to handle it. So I'm sure he'll heal. You may never see him again, but
Let's hope he heals. I mean, one other question for you is that every time I've tried to pack graft through a drill site, it's been an exercise in frustration. How do you really get it in there? Like, teach me how to do it properly, because I don't know if I'm doing it properly without any fancy devices.
I don't know if I'm doing it properly. I guess I haven't thought about it that much, but I tend to use Acumed. I am a little conflicted. But when you put your, when you do, when after you drill for a mini, and I use a mini AccuTrack for almost all of my scaphoids. I use a single mini for almost all my scaphoids. And there's a plunger in their set, which is perfectly sized to match the drill bit. And so I just put a little bit of soft spongy bone that I harvest from the distal radius through the same incision. And I think you can do it under fluoro if you like. You can do it without fluoro. Obviously, you don't want to pack it way past the non-union site. But I've been happy with that, and I really feel as though I get union in these cases. But again, in your situation, you did absolutely the right thing, the more conservative approach and the best approach, and that's the way it should be done.
So we harvested the bone graft cancellous, from the distal radius and packed it in directly at that area where we'd opened it up. Felt pretty gratifying. I think Sarita will fondly recall the amount of time that we spent harvesting that distal radius autograph together and how much joy it was. I think there's nothing more anxiety provoking as a fellow or resident is to have the attending just sitting there watching you try to scrape the bone out of the radius. And then inevitably you're like, wow, didn't really get that much. And then there's the few extra ones that the attendant gets at the end that you teed up for them.
Always. Always. And I may do mine a little differently than you do now. I have not personally had an EPL rupture from a harvest at Lister's tubercle, but people have. That is a known complication. I go a little proximal and a little radial to Lister's, and then I just use the smallest curette to sort of drill into the radius, and then a larger curette to do the harvest. I don't think there's anything wrong with Lister's, but and I'm sure you did, if you use Lister's, you just have to make darn sure that is a smooth interface.
No, you've taught me. So I actually go proximal and radial to listers, basically underneath the second compartment.
Yeah,
And that's reliable for me because I don't want to deal with that potential complication.
yeah.
So
And
yeah,
she,
we packed it and then we put a really Sarita put a really nice screw in. It was beautiful, and hopefully that's enough for this gentleman. One screw. So that brings
uh,
us to our topic of the first article. But before we get to that, I did want to mention that Checkpoint Surgical is proud to introduce its newest product, Checkpoint AxiCore Flexible Nerve Conduit.
engineered for flexibility and designed for the toughest anatomies. Its unique corrugated wall structure flexes with movement while maintaining an open, unobstructed lumen, helping protect the regenerating nerve without restricting natural tissue motion. To learn more, visit checkpointsurgical.com. I have to say, back in the day when I used those rigid conduits that were singular in size, and I put them in the finger, and I felt like, what the heck am I doing? This does sound appealing.
If there
It
was
really
only a
does.
flexible one with corrugated wall structures,
Hey, there
I think
is.
this is the only time that we said the word corrugated on the pod, so it's perfect.
We're hitting all the great vocabulary words. My daughter who just took the LSAT was throwing out some interesting vocabulary words that I'm always learning.
I've never taken the LSAT. I don't know if I'll ever have that opportunity, but my sister did, and I almost told her I was going to take it just to see.
It sounded hard to me.
So our first article that we'll discuss is from the group in Australia. So this is at Melbourne, and I know actually one of the authors, Eugene Eck, is a member of our travel club. But the last author is David Ackland. The first author is Karsten Surg, and it's called Fracture Fixation and Unstable Scaphoid Fracture Model, and then comparing a technique where you have a single screw and a wedge graft, or a single screw and a strut bone graft, or two screws and just seeing what would be more stable. So how often does this concept come into mind for you when you're actually putting in either a strut or thinking about two screws?
Yeah, it's for me. It's just not. Uh, it's just not a terribly pertinent issue for me, mainly because of my personal experience. I applaud the authors for tackling this topic and trying to provide some science behind rigidity, and their data are pretty convincing. The double screw group exhibited considerably greater maximum torque than the single screw and strut group and the single screw and wedge group. Also had higher stiffness and screw tightening direction compared to a single screw in both groups. I just don't, it's just not relevant for me. I really like my approach. I think for all of us, this is a volar approach. You're open, they did a simulated, obviously, osteotomy, but in our cases, we're opening a humpback deformity. We're packing bone graft in. I usually just use cancellous bone and I put my mini screw as volar as possible into the scaphoid. One of our partners does the Rousset technique with a corticocancellous distal radius graft, and another one of our partners does a iliac crest, either bi or tricortical graft. And so I have taken a minimally invasive approach to this and to most things, and do not feel like I've been burned. But what about you?
Would you still be putting your screw in through that now retrograde from that volar approach, or would you make a separate perc incision and put your screw in from antegrade dorsal approach after you've done the
Yeah,
volar?
right. I always go retrograde, and I feel like I can get a good screw in the center axis. It can be tricky for certain. I'm trying to think of pearls. I will open the STT joint. I will put a derotation K wire in, and that if that provides sufficient, temporary stability, then I feel like you can get a freer under the scaphoid to sort of lift up your distal pole to allow better placement of your screw with or without a takedown of a little of the volar trapezium. Um, but I understand some people like two screws and some people like a plate. I just haven't found as though I've been burned with a single screw.
Yeah, and it's important to know that you're mentioning that you like to use a mini, which I think is approximately 2.5 millimeters in diameter. And this group used I'll say the manufacturer because it is pertinent, but it was now I'm blanking on it. It's a 2.2 millimeter screw. It was a
2.0, I think.
Med Artist screw.
Okay.
So you have to be mindful to make sure you have enough actual room within the scaphoid. So this is not one where you're using a 3.0 screw or a standard AccuTrack. You got to make sure that you leave enough room to get both of those in. But it makes sense. It's intuitive that, a screw sitting more volar is going to be stronger than a relatively small bone graft, whether that's, the Rousset technique or I'd argue maybe a plate might be more rigid, but at that point, like maybe it doesn't matter.
I think, yeah, I agree. I think it doesn't matter. And, can you put too much into the scaphoid? I guess is a question. Is two screws too much? Will it affect blood supply? Certainly, that's not the point of this article, nor is it necessarily relevant to my knowledge. But I like the fact that this is a nice addition to literature. I don't think it's going to change my personal practice.
Right, and I'm hoping that neither of us is treating a lot of unstable scaphoid fractures or non-unions because it's just not fun.
Yes. All right. Let's move on. So our friend Warren Hammert led the way on suture button suspension plasty does not provide a sustained functional advantage over ligament reconstruction and tendon interposition for thumb carpometacarpal arthritis. The first author, I am not going to pronounce his name correctly. I'm going to go with Mwangi. Um, and I apologize to John if I butchered his name. But I like this article, sort of builds on some of the work we've done here.
Yeah, so they looked at a series of patients over 8 years at a single center. Presumably, this was done at Duke. But there were a total of 479 patients, and the vast majority of them, 409 patients, had suture button suspension plasty, a tightrope, and then 70 patients had LRTI. And it was interesting, I guess, from the work that we've done here that you have led. I would have expected to see more robust earlier functional scores from the suture button technique group, compared to an LRTI, but it doesn't appear that that is the case in this group.
Yeah, that's exactly right. That's what I would have expected as well. They give a good description of their surgical technique. I don't recall seeing exactly what they did with the patients after surgery. If it's in there, I apologize. Certainly, that is relevant. But you're right. There was not an early advantage to the suture tape or suture button suspension plasty. The other limitations of this paper, they're using primarily promise and a visual analog scale. Might there have been differences with additional? Oh, wait, here it is. All patients were placed in a postoperative thumb spica splint for 5 to 14 days, then transitioned to a thermoplastic splint for an additional 4 to 8 weeks. That's actually pretty novel in and of itself. That's really early for an LRTI, earlier than I have done, and occasionally still do an LRTI earlier than I would. So really interesting. Maybe it's the immobilization which has created differences, but nice contribution to help our understanding.
Yeah, I agree with that. This will be really interesting to see how these results endure, as we are going to see an ushering of articles about thumb CMC implant arthroplasty, given the global experience that people have had in Europe and um, in South Africa and other locations. Some of our partners are starting to introduce this and have done the training and are waiting for implant approval at our hospital. But I honestly would have expected a difference in early recovery. But I wonder how much of it is maybe the rehab protocol.
Yeah, I was thinking the same, along the same lines, because I had a conversation last night about implant arthroplasty, and I understand that the current implant is only a singular implant, to my understanding, is currently approved, and I've heard some astronomical prices for that, to the extent that some hospitals are not giving it a thumbs up, no pun intended, and but it does. This article makes you think: is it worth it for the $1,000, give or take, for the suture button suspension plasty? I mean, clearly this article suggests not.
Right, right. And I think the next steps would be to consider endeavoring into an RCT, which you are very well familiar with. But
No, thank
yes,
you.
obviously that's a big step. But kudos to Warren Hammond and the team at Duke for putting this article out there. And it's a lot of work to look through this amount of patients. Certainly a lot of time. So well done.
Yeah, and kudos to Warren, who was an early, um, I guess, utilizer in the hand space of promise scores when he was in Rochester, and really helped lead
Right.
the way to wide adoption. And we at WashU have followed his lead, and and University of Rochester's lead on that.
Yeah, and to your point earlier, I mean, this one that focuses on using promise as the primary outcome, and a lot of the literature in the past has used the dash or the quick dash, and they acknowledge that here, and trying to get, the crosswalk tables to see how, promise scores compared to quick dash and dash can be challenging. But it's good that there are more papers getting out there with promise, because ultimately I do think it's probably a better instrument overall. But it's just hard when you've got so many papers in the literature that are using dash and quick dash.
Right. I want to jump to, so I don't mean to steal your thunder, but another article got me thinking about cost, and it wasn't the intention, but uh, the Morisaki article on comparison of manual tie and knotless suture anchor techniques in arthroscopic transosseous foveal repair of the TFCC, with Takahashi being the senior author. I liked this article, and this is more in my domain than yours, but it just got me thinking. And so what they did was they took patients with foveal tears, and they had a large group, actually impressive numbers, 70 patients over 9 years. I guess maybe over that period of time is not that many, but they use the Mayo risk score and the dash, to your point, as well as visual analog score. And they compared essentially the knotless anchor and a manual tie of sutures, which, ultimately, I don't know how big a deal that is, but they found that the knotless suture anchor performed better and gave better results, better motion. What was interesting to me is their technique actually for the TFCC repair. Most of us use an ulnar tunnel, which is an Arthrex product. You drill a hole, and then your struggle is placing your horizontal mattress suture or sutures with enough spread in the suture. And their technique is different. They drill with a K wire. They then use an 18 gauge needle to puncture through the TFCC, and then they place the horizontal mattress that way. It's a nice little technique, which would save significant funds, and I think has a technical advantage. So I'm going to be, I don't, I think I knew this technique, but I really liked how they described it. The pictures are good. So sorry to belabor my excitement, but I
They
like this.
still they still manage to spend some money. They use the push lock for their sutureless
True.
technique. So I mean, they're knotless techniques. So I mean, but I think it is interesting to think about different ways of doing the same thing. How much more do you think that would save you without using that actual product if you still use the push lock?
Artex is a very savvy company, and everything's a kit, right? And the kit theoretically should save us money. I think
Arthrex, if you want to sponsor the podcast, we'll offer you a kit sponsorship.
that's right. We'll get you a deal, and a rebate, I don't know, because you have to pick the right suture, of course. But that'd really be your suture plus the anchor. Probably, you're right. Probably doesn't save any money. Oh well.
So have you found in your experience with your technique, do you find range of motion to be a limit here?
Yeah, in general, range of motion is not a limitation, but you do have to be careful. You can constrict motion. And I have had a few patients, and I don't know if it's a technical error, but you got the pre-styloid recess, you can't close it down too much, or if you do close it down too much, you will lose motion. So I try to be aware of trying to really put my stitches at the footprint of the ovial insertion. Sometimes I visualize that with a sub TFCC scope, and sometimes I'm using, kind of the force. But you can restrict motion with inappropriately placed sutures.
Do you think it's more wrist motion or forearm motion?
Usually it's rotation, yeah, so forearm motion.
Yeah, so I mean, it's important to recognize that in this article, when they had this was a retrospective, comparison, but both groups did well. It's just a matter of for the not list, there was a slight difference in, in dash. I think it was, yeah, dash scores and wrist flexion. So, that's something to keep in mind. Both groups did well, even with that manual tying technique.
Yeah, for me, this has been one of the biggest innovations in my surgical technique is appreciating foveal tears over the last 10 years and finding the right way to fix them. So you take that black box ulnar side wrist pain, and now it's a little simpler, I think, to make people better. I wouldn't say easy, but I have steps I take to make sure we identify hopefully the cause of the pain and address it.
Demystifying the ulnar side of the wrist. I think
Let's
it's been an
go.
ICL every year at the Hand Society for 15 years.
It's still a mystery.
Still a mystery. So, a couple more, or three more articles to go. Um, how excited were you to read about surgical treatment of mallet fingers?
Well, you're gonna laugh because I did this case yesterday,
Are you
and
serious?
I did. It was a chronic mallet. It was markedly displaced. It was in a younger patient who couldn't get his finger up. And after reading this article, I kind of wish I'd seen it or read it in more detail and considered using it. This technique is kind of slick, but I hate dorsal pens. I hate them.
Yeah, so this is an article from Seoul. The first author is Sung Hoo Lee. Last author is Young Ho Lee, and this is surgical management of delayed mallet finger fractures using a combined two extension block K-wire and dorsal counterforce technique. So it's the case series of 29 patients with delayed bony mallets, which, man, can't imagine treating 29 patients with delayed bony mallets. But can you describe this technique in terms of what's novel about it?
Yeah, so if you are a hand surgeon and you have a patient like this, go to this article because it's really nice when the images or the figures capture a technique because a picture is worth 1,000 words. And so,
Yeah.
the dorsal, first of all, you have to break up the area that hasn't healed. They did that percutaneously with a K wire. Um, and then they placed two dorsal block pins. And I think the point there is that sometimes one dorsal block pin is not sufficient. And then they're using an additional haywire to tamp the fragment in place and potentially to leave that pin in place. And that is great. It's not, these pictures are remarkable and the cases they share are remarkable. Um, my results are not always that good, is the bottom line. I think these can be very hard. Opening them always sounds good, but opening is not easy either. And in some cases, opening it, you get a worse result. So I really like this technique.
Yeah, no, it's really, and I agree with you entirely. The figures are fantastic. So kudos to the authors for making this very accessible and understandable to us. These are tiny wires though too. So I mean, I think we're thinking 3.5 and 2.8 wires if you're translating from the metric into the imperial. So it is this can end in heartache, especially with opening. So kudos to them for this work and for demonstrating that this is a very effective technique. It's not one that I want to employ anytime soon, but sometimes the moment strikes.
Yeah, I did the other this is going to sound really silly to bring up, but I have to say I think it's important. If you place a longitudinal K wire through the tip of the finger, the struggle is can you get the distal interphalangeal joint reduced because for me I'm usually doing this when there's a subluxated joint. Can you get the joint reduced and keep your longitudinal K wire out of the way? So in other words,
Yeah.
don't let it block your reduction. And they didn't try. They placed a longitudinal K-wire in some of these patients, but they used that volar expansion of the distal phalanx, and they started their pen more volarly. So they sort of slid under the distal and mid aspect of the distal phalanx, engaged the distal phalanx only just distal to the joint, and then drove it across the DIP joint. It sounds like a silly, obvious thing, but I think it's a nice little trick to remember.
Oh yeah, that makes a huge difference in terms of giving yourself more real estate for your dorsal base pins.
Yeah.
So yeah, I mean, clearly they've thought about this and have probably lived through some of those challenges that you described.
Are you saving your favorite paper for last?
Although there's actually one more paper before that, but
I know, I know.
But
Huh?
let's go to the paper that I enjoyed the most, I think, out of this group. So this is from the group at Mayo. Ray Lunasin is the first author. Alex Shin is the senior author, and this is Rethinking Muscle Testing: Dynamic EMG Studies of Elbow Positioning as a Differentiator of Pronator Teres and Quadratus Functions. So I don't know how you were trained, but I'm pretty sure we were trained by some of the same people. If you're trying to differentiate the pronator teres and pronator quadratus, I was taught to flex the elbow and then check resisted pronation because that will try to isolate the pronator teres as much as possible because the PT can also, because it comes off of the flexor pronator mass, crosses the elbow theoretically. So when you check up in elbow flexion, it should isolate the PT more. And then when you check out an extension, it's a little more challenging to differentiate PT from PQ. So I don't know why Alex got really excited about writing this article. I think that perhaps there was some discussion about selecting nerves for transfer or selecting tendons for transfer. But does this come up in your world a lot, Chuck, in terms of like, trying to differentiate?
No, I can't say that it does. Maybe it should. I do, check for if I'm worried about the median nerve, that's the only time I check for elbow extension resisted pronation. But no, this is not in my world.
Okay. So, and just to make sure everybody's clear on it, I will read from their article. It says pronation strength testing with the elbow fully flexed is thought to reduce the PT's influence, where full extension emphasizes its role. So then that's just something to keep in mind. Honestly, I think this is a really cool use of their technology. They're showing off all their cool motion capture stuff, which is really neat. But the long and short of it is that when you can't differentiate, there's contributions from the PT and PQ in all positions, whether it's elbow flex all the way up, elbow flex at 90, or elbow fully extended, which I think is interesting. For me, in my context, I'm still going to have somebody put a needle in the PQ if I want to use the PQ. And that needle is going to be inserted under ultrasound guidance just to make sure it's really in the PQ. So interesting food for thought, but probably not something that's going to change a lot of what I do right now, aside from kind of the counseling.
Yeah, I mean, again, I applaud the authors. It's a really long run for, I don't know about the length of the slide. It's a big effort, and it does create a lasting contribution that might not change many practices, but I applaud the authors. Thank you.
Okay. And then why don't you bring us home with maybe your favorite article of the group? I read this
Yes.
article. I thought Chuck is going to love this one.
Yes, I mean, the title of the article is Understanding Why Certain Patients with Hand and Wrist Conditions Are Dissatisfied Despite Achieving Their Expressed Personal Improvement Goals Anchored at Satisfaction, a qualitative study. So, this is a study from a European group called the Hand Wrist Study Group with really good people. Stephen Hovius made his name in congenital hand surgery. He's a friend and mentor. And De Ritter is the senior author, and Arends is the first author, and it's a little bit complicated, but I'll cut to the chase. So there's a construct called the personal meaningful gain, which identifies patients' self-defined improvement goals. And so, what's going to take to be happy? And what they did was they used the interpretive phenomenological analysis for their semi-structured interviews. They collected data. They had a validated personal meaningful gain identified before the initial visit, and then they interviewed patients who met it or didn't meet it, and they identified a number of themes. And their conclusion was the PMG is valid and predicts satisfaction, but some dissatisfied patients may have expressed a PMG that was only a means to an end. Positive care experiences could ameliorate dissatisfaction, but they rarely resolve it completely. So it's the point of the study, and maybe you can add some context, is do our best to understand actual goals. And that's our best way of helping patients achieve their desired result, but it doesn't guarantee that if you do achieve those results, the patient will be satisfied. Did I do a reasonable job capturing that?
Yeah, you basically captured all of peripheral nerve surgery and brachial plexus. But
You,
this is so real in our
yeah,
world. I mean,
I
like
bet
this
that's
is
right.
very common. And I also would love to hear you say phenomenological again, because that was pretty awful.
Did did I? What did I say? Is phenomenological is how you
roll,
pronounce it?
roll the tape. But I really like this paper because it incorporates. I have done in the past a fair bit of qualitative research to try to understand this dissonance between patients who should be happy and aren't actually happy. Because I mean, anybody who's heard me speak on kind of nerve outcome assessment has probably seen me show the example of a patient who had a home run brachial plexus reconstruction result and looked me in the eye and said he hated it. And I just like my jaw dropped to the floor. Like I was celebrating his M4s and his, for shoulders and elbow, and he's like, "Yeah, I don't like it." And it's because we did not level about these kind of goals, ahead of time. So I think that really talking to patients about what they want out of whatever you are offering them is a critical step, because it's easy very early on to focus on the things that are easier to measure and easier to obtain. But if they have specific things in mind, it's best to level about those very early. But it's really hard as a young surgeon to be like, I can't do that, or I don't think you're going to be able to do that, fully knowing that they might say no to whatever surgery you think that you're going to offer them, you think would actually help them, but they don't know it. I hope that makes sense.
It does make sense. I mean, I think this really is, again, your world, and interestingly, rarely mine. I wouldn't say never, but I don't have goal. I talk to parents about congenital anomalies and realistic expectations, but that's just different. So, thankfully, in my world, the goals of surgery are more straightforward, but honest conversations, especially in your world, but maybe in all of our worlds, are really important to make sure that what we offer can help goal achievement.
I don't think you really know what you can offer until you've been around for a while.
True.
Because you know kind of what the textbooks say, you know what your mentors have told you. But all it takes is, a few patients in which you feel like you let them down, or they let you know that you let them down in terms of, well, I still can't do this. You said I could do this. And and then it's like, well, you just gotta do it more and see it more and be around it more to be like, all right, I think this surgery can allow you to do these things. What are the things that you at in a year or 2 years, what will you call a success or a victory? And then you can say, I don't think you're gonna be able to do that. And fully knowing that they may go ask to see somebody else or they may leave upset. And it's challenging. That's hard. That's the hard part about being a surgeon. I think for a lot of the stuff that we do is sometimes you are not able to meet the expectations of others.
Really interesting. And I think a great way to finish.
On that happy note, so so we've got a couple more episodes before the Hand Society live episode. I think it actually is just two. So if you want to hear about something, let us know. I think we still have on the docket to have some tips for new fellows starting up and people starting out in practice. So look forward to having that conversation again soon.
Awesome. Have a great day.
You too.